Welcome to The Essence of Recovery, a podcast from the Athens Area Commencement Center, a space for honest stories and meaningful conversations about healing, growth, and the experiences that shape our lives. In today's episode, we're joined by Dr. Merrill Norton, Professor Emeritus from the University of Georgia College of Pharmacy, and a clinical pharmacist who has spent decades studying addiction, brain science, and psychopharmacology.
In this conversation, we take a closer look at what's happening in the brain when someone develops a substance use disorder. We talk about dopamine, genetics, and how addiction changes the brain's reward, memory, and decision-making systems.
We also explore why behavior that looks irrational from the outside can actually make sense within the brain, and why willpower alone is not enough. This is The Essence of Recovery. Music provided by Shauna and the Jaywalkers.
Well, thank you, Merrill, for joining us today.
Thank you.
Glad to be here. Thank you.
We're excited, and you represent a wealth of knowledge with your background and expertise. And so we wanted to start with kind of a sciencey question. So when someone develops an addiction, what is actually happening?
Well, I'll say it this way. It's extremely complicated because it's phased. And there's phases. There's an early phase to the process, there's a middle phase, and there's what we call a latent or a dependence phase. And then there's a fourth phase that we hope people, when they understand the disease, that there is treatment, and there's treatment for it. And there's medications that we can use and those things that we will discuss. But the thing about it is, a lot of the science that we've studied has been updated recently. And so I'm in the process of trying to put all that together. So when we look at the neuroscience of addiction, or what we call a substance use disorder, and they use that term to reduce stigma. We're trying to reduce language that make people feel bad about what may be going on, and we'll discuss that. So we're going to use substance use disorders as much as we can. To make it very simple, addiction or substance use disorder is a progressive rewiring of brain circuits. It involves the reward part of the brain, it involves the motivation part of the brain, it involves the memory part of the brain, and especially the self-control part of the brain. And this is what we see. So, as most people know, when you start to drink or use a drug, it creates a great feeling or a good feeling. And that is because of a chemical in the brain called dopamine. Now, dopamine is very limited. We're not supposed to feel euphoric for very long periods of time. If we have a good meal, we feel that, or we make love, we feel that, or somebody gives us a hug, we feel that. But dopamine is extremely limited in its activity. It has perceptual activity in the midbrain so that we can see the world as it really is. If we have an imbalance of dopamine in the midbrain, it creates psychosis, schizophrenia, those types of issues, hallucinations. So we've got to be very careful in how we use it. And so the brain has regulatory systems that creates that limitation. So when you start to drink and drug, it starts to stimulate initially early phases of the brain and makes you feel good. And if you use on a regular basis, the brain begins a memory system of saying, I really like what you're doing. I'd like for you to do it again and again. And this is where, again, what happens, the first phase is that reward system in dopamine is beginning to be rewired. It's beginning to say, I prefer this behavior over a normal feel-good. And that is a very subtle thing. And so we'll talk a little bit about the genetics, but that's the first thing. So it's a rewiring, basically a rewiring based on dopamine and the levels of dopamine in the brain.
You talked about genetics. Is this rewiring? Is it a normal person that encounters these substances and then their brain gets rewired? Or is there somebody with a genetic predisposition that's more susceptible? Are there two different processes?
Excellent question. Being a pharmacist and a pharmacologist, the one thing that I have been trained to do with individuals with prescription medications and even over-the-counter medications is the dose. You've got an effective dose, you've got what we call a therapeutic dose, and then you have an over-therapeutic dose, and then you have a lethal dose. You have all these doses. And so the thing is, a person with normal genetics, no family history of depression or mental illness, no history of suicide, no history of any kind of addiction, can take methamphetamine, for instance, which is a very highly addicting substance, which creates a quick tolerance, and create an addiction.
Okay.
Because it changes what we call the messenger RNA in the brain. And once that messenger, that's your day-to-day genetics, that's your DNA every day. And that changes every day. That's how we change and how we have preferences and how we have new experiences and all. It's that messenger RNA is changing our brain and how we can see the environment that we live in. And so as a result of a person with normal genetics, no risk factors, they can take a highly addicting substance in high doses over a short period of time and change the epigenetics of their brain to lead into a active substance use disorder.
Okay.
It is not, so anyone that uses psychoactive substances on a prolonged period of time, especially the psychostimulants or the opioids, even with the best of genetics, can develop a substance use disorder. So there's no one immune. Now the genetic part of it is very significant in that we have basically a type 1, a type 2, and a type 3 genetic type. Type 1 is the adult onset. In other words, it can be a male or a female, can get a genetic connection either from mother, father, grandmother, grandfather, whatever it may be. It takes an average of 12 to 15 years of active use to develop a need for treatment. Now, that's a type 1. Very treatable, very treatable. A lot of people, those go to, in fact, 75% of AA is made up of this type of individual, we think. And what happens is that those individuals can seem to gain their control back by various behavioral modifications that they discover through either mutual help groups or treatment or both.
Okay.
You understand?
Yeah.
Then we have a type 2. Type 2 is more malignant. It's the most malignant form, I should say. It's father to son or grandfather, father to son. These individuals have a great deficiency in that dopamine system that we mentioned earlier. And what happens is when they drink, it initiates the dopaminergic system that is lacking to normal levels. And so what happens is they become very functional under the influence. So they can drink high amounts of alcohol, have high tolerances, don't even seem that they're intoxicated, do great creative things. We have lots of talented musicians, authors, career folks. I've treated many healthcare professionals, physicians, pharmacists, nurses, nurse practitioners, very brilliant folks. But the thing about it is, as a result of their genetics, under the influence of whatever their drugs may be, they function very normally. The problem is when they stop, then they go back down to zero, and that's when they have high amounts of anxiety, depression, suicidality, very, very dysfunctional.
Yes.
And then we have type 3, which is the female version of type 2. We've discovered that over the last decade. So the mother passes it to daughter, or grandmother passes it to mother to daughter. And the thing about it is not as malignant as the type 2, but it's extremely difficult to treat. Women have a dual-edged sword in our culture, not only because of the active substance use disorder, but all because of the stigma that's attached to women. So with those three types of genetics, you can have use at a very young age and create a substance use disorder within a year or two. You could have it in their 20s or 30s. It takes about 3 to 4 years for it to show its active need for treatment. And then you can also have it, what we're seeing is in the senior population, these individuals who never drank or used but had the genetic predisposition. They were very creative in other ways. They start using it, and all of a sudden they end up in a very short period of time needing treatment. So,
wow. Having led a seemingly normal life up to that point.
Usually very compulsive in a positive way.
Yes.
They create corporations, CEOs. They become very productive as far as women or men. But they have isms,
Yep.
like a lot of people have, but it doesn't have a drug association to it until they retire. And then I had a father who was very productive. He was very involved in his church, created a very successful construction company, made a multimillionaire, basically. And then when he decided to retire, he decided he would relax and start social drinking. Within 2 years, he's a full-blown alcoholic. And so we had to intervene on him, and we treated him. And fortunately, because of his spiritual background, he was able to get sober, and he stayed sober. He lived up until he was 95 years old. Yeah.
Okay.
So that was a good turnaround.
Yeah.
So that's an amazing thing that can be laying dormant, seemingly dormant, and then manifest later on in life. Mm-hmm. Then the other thing, the type 2 malignancy in our culture, I grew up as a male. I went to college. I have sons that are in college. That's almost referring to someone as having a wooden leg, or they can drink everyone else under the table, and there's almost a source of pride around the person that can do those things. Well, that's really a kind of a canary in the coal mine as a potential warning sign for future problems.
That is correct. High tolerance is not a good thing from the standpoint of the high risk factor for substance use disorder.
So not something to be proud of.
That's exactly right. So it's scary, and most people, the thing, and I appreciate what y'all are doing in your podcast. Most people don't know this. In 2026, I've been teaching this type of information for almost 40 years.
Yeah.
And our culture, we live in a chemical culture.
Yes.
You have all kinds of things that you can drink or use, and it's acceptable. It's kind of what people do. And unfortunately, our risk factors are continuing to increase because of what I told you earlier, the genetics. See, when you change your messenger RNA, you also can change the codes in your DNA that can be passed on to the next generation. So you can have a negative family history, use a high-end drug, develop a substance use disorder, then that genetic code can be passed on to your children.
Oh.
So it's called epigenetics.
Goodness gracious.
And it's not just for substance use disorder, it's for lots of disorders. It's lots of different things can happen, and that's why the epigenetic world, if I was a young guy, that's where I'd spend my time, because we're finding a lot of good and bad things about it. So,
goodness, so it's not just behavioral observation, it's actually passing down genetic information onto, oh, goodness.
Yep.
Wow.
So you change the dopamine. It's the first thing that happens to create this substance use disorder. And then what happens is there's a change in the learning and memory systems. It's called a pathological conditioning, to where the brain then starts preferring the drug over the behavior, or the drug over the family, or the drug over your workplace, or whatever. It's a subtle process.
Does that explain how people with substance use disorders, their behavior becomes irrational to everybody but them?
It does, because the brain doesn't look at it. They don't perceive it as irrational. Mm-hmm. The brain circuits have changed to where the drug is needed. And so everything that makes that happen, the brain says that's normal. Mm-hmm. Even though they're drinking, a 12-pack or 24 beers at one setting, to them in their brain, in their perception, that's one thing that happens, is, again, this change in learning and memory. That's a level that people don't really talk about much. And then the loss of control. The loss of control occurs in what we call the prefrontal cortex, which is your planning brain. It's your thinking brain. It's what gets you up in the morning. It gets you dressed. You have your breakfast. You make your choices. Well, see what happens in that prefrontal cortex. It begins to lose. So you lose your judgment. It loses your capability of inhibitions. It loses your future planning, and it becomes what we call hypofunctional. In other words, the prefrontal cortex doesn't plan. It gets up and it just happens. And so when you have, and we'll talk about this other part, when you change that part and then you change the instinctual brain, the hypothalamus and the hippocampus and all of those things, it sets up a cue. And so if you're not really got a plan that I'm not going to drink today or I'm not going to think about it, the cue on the instinctual brain says, have a drink.
Yeah.
Have a cigarette. Do a line of Coke. Just, it pops up, and guess what? That's what the person does. Mm-hmm. And yes, it's extremely irrational from the outside, but on the inside, the brain is it is operating as normally as it could be based on the rewiring of these circuits. That's why we call it a disease, y'all. It's a neurological disease that changes these circuits. And once you change these circuits, it becomes irreparable. You don't change them back just because a person stops using. Mm-hmm. And that's the problem that we run into. That's why detox of a substance use disorder doesn't work without further treatment. Mm-hmm. You know, that's an important thing for people to remember.
Where does willpower fall in?
Willpower is a prefrontal cortex application.
Okay.
So if you have a dysfunctional prefrontal cortex, guess what? Willpower doesn't work. Willpower is not even activated. Willpower doesn't have a thing. That's a conscious theory. You ask about the irrational part. So let me answer that question in one sentence. What looks irrational from the outside actually reflects a brain whose priorities and decision signals have been reweighted. The same behavior that seems illogical to an observer is, inside of the addicted brain, is highly consistent with altered reward, learning, and control systems that make it normal.
Okay.
That's the irrationality that you see, the family sees, but the individual doesn't see. Remember now, that's the part about that. And then the other part is this. So let me say this. So you change the prefrontal cortex, you change the genetics, you change decision making, and then you change what we call the prediction error signals. In other words, we have signals in our brain that say, that's too much, we need to stop, that's dangerous, I can't do this, look out. It's based on the amygdala. It's based on a fear that something bad could happen. It's what we call a prediction error signal. So what happens when people are using psychoactive substance, that system gets hijacked and unplugged. So guess what? It says, normal dopamine says, better than expected, repeat. Drugs produce artificially huge prediction errors. So when you use a line of cocaine or drank 3 beers, you feel super good, the brain says, that's really something I want to remember. Yeah. And the prediction error says 1 is too much or 2 is too many, it goes away. So there's no prediction error system. It's hijacked, it's taken offline. Very similar to the prefrontal cortex, it's taken offline. And that's what I keep saying, that's what the rewiring is about. So you have to be really careful.
There's real science between it. There's a joke about someone will say, here, hold my beer, while they go off and do something exceedingly dangerous. There's real science behind that.
That's correct. That is correct. And now, the issue about why doesn't willpower work, even when someone desperately wants to stop? That's a great question. Willpower relies on the brain systems that addiction specifically weakens or bypasses. So even when someone genuinely wants to stop, the neuromachinery needed to carry that intention out is compromised or shut down. So willpower is it's hijacked. You know, the people talk about hijacking of the brain. It has multiple systems that are actually taken offline, and then the brain is only going to be concerned with one thing. The only thing that I need is that drug. That drug is what's going to make me normal, and it's going to make me survive. That's the thing that most people don't understand about why this disease is so difficult to treat, is because once you change that instinctual system, drug becomes survival. It's better than sex, it's better than food, it's better than love, it's better than family, it's better than careers, it's better than all of that. And people throw all of those things away to do what? To get their drug of choice. Mm-hmm. But that has to do with a biological disconnect. It's like disconnecting prefrontal cortex, disconnect your memory system, your learning system, your willpower system. All of those things are disconnected, and the only thing that's connected is that drug is needed for survival. And that's the one thing. And science is showing more and more of that.
I heard there was a presenter and described his perception of his substance use disorder was it's the same feeling as if somebody submerged your head underwater and was holding you under, the desire to survive and get another breath. And that's kind of eerily similar to the science that you're talking about. It's that compelling.
Exactly. In other words, it becomes the most important thing in that brain's world. Remember, the brain is going to seek what it does not have. It's going to tell you what it's got to have. It does that normally. It tells you when to eat.
Yeah.
It tells you when to, get out of the rain. It tells you how to protect yourself, how to survive, fight or flight, flee, all those types of things. All of that changes because everything is focused on that drug of choice.
And there's examples of this. This is like those rats in a cage that forsake everything else, food and everything, for cocaine or some other substance.
Well, we've seen it when I was in the 80s, and they were studying the rhesus monkeys at Emory, and they would hit that button for cocaine instead of that button for food, or that button for sex, or that button for water, and they would actually punch that button until they died. And then they had to discontinue that because of the harm that it was causing the animals. But the thing about it is to see that's how this brain is overwhelmed. See, the problem we got, y'all, is that with all this information out here in this chemical culture that we live in, we're only going to see 3 to 7% of the individuals who need treatment ever seek treatment. 90% plus will never seek treatment, and they will die prematurely. Some die 40 years prematurely, as we've seen with the opioid epidemic. Some people die in 50 years prematurely. The average age of the overdose death individuals 27 years old.
Goodness.
I mean, the thing about it is, that's why we've got to do more work at trying to get people help at any level that we can.
So these folks, there's all this stuff that's going on, and they don't really perceive that anything's wrong.
No.
And there's 100 different things going wrong.
Well, there's another issue that has come up recently, and I think it's the most fascinating issue that I've seen outside of all the stuff that we've talked about. These psychoactive substances create this neuroinflammation. And neuroinflammation is different than normal inflammation. Inflammation, if you hurt your hand or something, you'd see swelling, you'd have pain, you'd seek some sort of help. There'd be some signal that something's wrong. Neuroinflammation has none of that, has no symptoms. It's silent.
Yeah.
And it is what helps block. First, it affects the area of the neocortex, the outer layer of the brain, and it inflames it. And so what that does, when it inflames that neocortex, it begins to alter the blood-brain barrier. And that blood-brain barrier, which is right next to the neocortex, it begins to have, it's a filter system. So when we go out here, for instance, this pollen, and we breathe this pollen, 99.9% of that pollen will never reach the brain. None of those molecules will ever reach that brain because we have that filter system. You understand? Because it screens certain molecules, small molecules and certain large molecules that allow the brain to function normally. What happens when you have this neuroinflammation, as we've seen with Alzheimer's and other dementias, and we've seen it in the lung tissue with asthma. We've seen it in the cardiovascular tissue with individuals who tend to have damage to the heart. As a result, leads to strokes and heart attacks. It inflames it. And so at the blood-brain barrier, what it does, it creates more holes. It's like creating holes in a dam. Mm-hmm. And so all of a sudden you have these molecules that are not supposed to enter the brain go into the brain. So we have these psychoactive substances, kratom, for instance, teneptine, some of the gas station drugs.
Yeah.
All of a sudden they're going into the brain, and guess what's happening? You're having damage as a result of that. And so one of the problems that we've got is that neuroinflammation inflames the inner area, and it blocks, and it's part of not only the rewiring, but it blocks, even with a normal signal, it blocks the signal and capability of the brain. So for us to say no, and us cognitive to say no to our brain, we don't want to do that. It's blocked, and so guess what happens? It is another impairment.
Yeah.
And so what we have to do to treat it, and that's what we need to do with treatment, and what I've just did a pretty remarkable, found some remarkable research about the effectiveness of the 12 steps and how the 12 steps in spirituality begins to reduce neuroinflammation and how it changes. So you have a step 1, a step 2, a step 3. That'd be enough for another talk. But the thing about it is, as it changes the brain over the years of recovery, so by the time you can rewire this brain from a substance in a short period of time. If you're adolescent, 2 years or less, adult, 10 or 12 years. But to get into recovery, it takes much longer. So the average return to some sort of normality once a person stops using, and if they go to treatment or whatever they may go to mutual help groups or both, 5 to 7 years for the brain to start returning back to some sort of normality.
Oh, goodness. So
and that has to do with the neuroinflammation, is my belief. As I see it more and more, the neuroinflammation has got to be reduced. I just recently had brain surgery almost 2 years ago. And my left side, as a result, I had a benign tumor in my ear canal, about 3 centimeters. And so they had to have the tricular nerve was a part of on the tumor. Tumor was on that nerve. And so it had to do with my hearing, it had to do with my facial muscles, had to do with all my sensory on the left side. And so when they took it off, they affected the facial muscles some. And so this side has been paralyzed for almost 2 years. So I'm about 95% back. So my tongue, I can talk, I can taste, I can do all those things. And I'm having to take several things. And one of the things I've discovered recently that has helped me more than anything else is grapefruit juice. It's one of the best natural anti-inflammatories. I can't take non-steroidals because of my stomach, but the thing about it, and some people have allergic reactions, but the thing is, as I've been taking about 3 glasses of that a day, my face has come back and the whole thing. And so what I'm thinking is we're going to put together a set of dietary things that would help. And that's why some of these new diets are so helpful, especially with dementias and diabetes and other things. So it has to do, but it has to do with neuroinflammation.
And I really thought at some point when I was first in this world that people were talking about it's a brain disease, and I thought that was kind of metaphorical, but you're referring to actual inflammation and
it actually
just destructive things. There's things actually happening.
You actually can see in the what we call the glial cells. In the neurons. So we've got millions of neurons, or nerve cells in the brain, and attached to them are what we call glial cells. And the glial cells are support cells. It's kind of like, we've got the astronauts in space right now, and they've got all these systems that support their oxygen and their water and all that. Glial cells feed the neuron, they clean the neuron, they provide nutrients. They're extremely important because all the neuron does is convert chemical messages into electricity back into chemical messages, so it will go from one area to the other. Neuroinflammation attacks those glial cells, and when you start to attack the support cells of the neuron and they begin to die, then guess what? The neuron dies. And so with methamphetamine, we've discovered that the prefrontal cortex is inundated, and there's lots of destruction in the prefrontal cortex as a direct result of that. And so the thing is, to recover from methamphetamine, high dose of methamphetamine takes years and years. Alcohol and Wernicke's, in the Wernicke area of the brain, right below the parietal lobe, you can have it start to shrink that area, and so and it starts that inflammation, and then you have that wet brain, And so the thing is, and it takes years for that to happen, but the thing is, it is what we see with most of these psychoactive substances, and they're all related to this neuroinflammation that we have discovered, besides the rewiring and all the other systems offline. But it really has to do with the neuroinflammation. So there'll be a lot more information coming out about that over the next several years.
Yeah, we talk so much about, that you could have a difficulty with a substance over 15 years, and then in our culture that you can go to rehab and then you're good to go, but it takes as much time to kind of get out of that hole that you've dug.
Well, it does. It takes a while to do that, and then unfortunately what we discovered that the neurochemistry that you had before you started using never returns back to that same level. Now, some of that has to do with the aging process. See, as we peak, we start our peak, women will start their peak about 24, 25 neurologically. Men will start their peak about 28. They have about an 8 to 10 year period that it stays at that level. So when we get to 33 to 35, we begin our perimenopausal years. Men will start, their testosterone starts dropping. Women's estrogen and progesterone starts dropping. And we go into perimenopause. And then that goes on for about 10, depending on individuals, maybe up to 15 years. And then the hormones stop. And as the result of that, the brain begins to shrink. We begin to age. The normal brain begins to shrink. And we begin to have short-term memory losses and all those changes in our body. Our blood pressure goes up, and our eyes don't work as well, and our hair turns gray if we have hair. All those things happen normally.
Right.
Psychoactive substances prematurely age that brain.
Yeah.
And so what happens is when they take that, then you never return back to that same level. That's why we call it a chronic disease. That's why relapse happens. People can have a few months, of a few years of good, solid recovery, going through a high-stress situation. See, that's the other issue that I haven't mentioned, is that it impacts the stress system. In other words, a substance use disorder brain is a high-stress brain. It's running fast, as fast as it can go. So you add any more stress to it, guess what happens? It can't manage it, and that's where they go back and they use their drug of choice as their stress management system. So,
That's a solution.
Exactly.
Self-medicating.
Yep, that's exactly what it's about.
Yeah.
And they use that as a part. And that, again, the brain looks at that as being normal. You understand?
Mm-hmm.
But it's going to seek what it doesn't have. That's the normal activity of the brain for any of us. So if we're hungry, we're going to eat. If we're horny, we're going to have sex. If we're thirsty, we're going to drink. You understand? That's what the brain does to survive. Well, see, when you have that fourth drug as a part of your survival, it will then seek. And so you have these cravings that continue. So,
where does medication fit into the picture?
Medications are the present.
Okay.
When a person takes a medication, it is the present. In other words, it's going to treat what the brain needs at the moment. So it is a short-term answer to a long-term problem. And medications will change cravings. They help with stabilization of withdrawals. They help with mood stabilization. They help with supplementing what the body needs. If it stimulate hunger, it helps quench thirst, those type things. That's what it does do. But guess what? It doesn't change the memory system. It just change. It doesn't. They don't change the learning system. It doesn't change the person's ability to ask for help. It doesn't change the need for support. It doesn't change the consequence review of what could happen if I take another drug, even after treatment. It doesn't change any of those behaviors. Mm-hmm. And that's what treatment is for. It is a behavioral modification model, biopsychosocial model that intervenes with a person on their physical needs, their emotional needs, and their spiritual needs, and along with their family needs, you understand? Mm-hmm. And that's why people need that type of support. A drug doesn't do that. A drug is not going to fix a relationship issue. It's not going to fix a career issue. It's not going to fix any type of dilemma that may be a cause as a result of the use. But medications are extremely important in stabilizing in the present what the person needs in order for them to get well enough in order to respond to the behavioral modifications. You understand what I'm saying? So detoxification is important. Mood stabilization is important. Those types of things, that's what medications will do. Stopping cravings is extremely important, especially the first 6 to 12 months, depending on what the drug is.
Yeah.
So they're very beneficial from that standpoint, but they're only for the present. So what has to be introduced into the individual is motivation to continue the process day after day after day after day. That's why they have to have mentors or in mutual help group sponsors. That's why they have to have therapists, counselors. They need spiritual guidance, those types of things. But you know what most people don't understand, dopamine is what you're trying to stimulate in recovery. And I told you it's very limited, and even after a substance use disorder, it's even more limited. So you're going to have to repeat daily these activities. So there's the Fabulous Five. The Fabulous Five teach us how to increase our dopamine. One, you don't drink or use. You find and go to a support meeting, because at that support meeting you can find people who doing the same thing you are and will help you understand what you need to do. You need to find and call a sponsor. You've got to have a teacher. You didn't develop a substance use disorder overnight, and you're not going to get in recovery overnight. So you've got to have somebody teach you what you need to do and all this stuff. And then you need to work a spiritual program. The one that seems to have the most success is the 12 steps. Be Alcoholics Anonymous or Narcotics Anonymous or Emotions Anonymous. And the biggest thing you have to do is repeat daily, because dopamine does not accumulate. It's a day-to-day thing. So you get up and you say your meditations, and you call your sponsor, and you go to a meeting, and you had a good day, and then on a bad day you do the same thing. And the thing that's interesting, having seen over 35,000 patients in my career, every one of them that had a recovery program, the first thing that they gave up was going to meetings to where they could actually reunite with people who are doing it. Now, what we've discovered recently is that going to meetings increases the dopamine by 50%.
That's a lot.
It's as much as you can increase it that I can know of. It's better than a foot-long hot dog, so to speak. So somebody likes foot-long hot dogs. But the thing about it is, it's like going and you see these people and you get excited about seeing them, and they get excited about seeing you. But the thing about it is, it's the effort it takes. That brain is going to tell you when you get up that morning, if you got a substance, I don't need a meeting. I don't need the steps. I don't need to do that. It's going to, because that brain, it's a chronic disease, it's going to continually tell you, I don't need this. It's kind of what I said. The core statements of addiction is two. I can do this all by myself, trying to figure out if I can stop or not. I can do it all by myself, which is normal. It's problem solving in the prefrontal cortex. But if a normal brain doesn't figure out how to solve a problem by itself, a normal brain will simply say, I need some help. But see, the addicted brain, the substance use disordered brain, is on the survival level. And instead of saying, I need help, well, guess what it says? It said, leave me alone. Leave me alone. It's a survival instinct. And that brain has said, that drug is going to do everything you need, so leave me alone. I don't need you. And what recovery is about is being able to ask for help. So what people have to learn every day when they get up and that brain is telling them, I don't need it, it's, I need some help. That's when you call somebody. That's when you go to a meeting. That's when you work a step. That's when you get a program involved. And it's an important component to manage the chronicity of this overwhelming brain disorder that has rewired your brain, that will tell you your drug is the most important thing over everything in your world. And you can ask anybody who's in early recovery, they've taken this drug. Mamas take that drug over their children. And daddies take that drug over their jobs and their careers. And many times, all of those things. But that's why recovery a day at a time is extremely important, and that's why the ritual of recovery and repetition. The other thing about this dopamine is that it increases slowly, but you've got to repeat the same behaviors day after day after day. And that's the thing. It kind of reminds me of how the brain helps people recover from strokes. If you have a stroke and you're fortunate enough to get to the ER, and they give you the clot busting drugs, and they bust up that clot that stopped, that blocks, and they brought you back, but you have paralysis on your left side or your right side, guess what they're going to do? They're going to put you in occupational therapy. Mm-hmm. And that therapist is going to come in, they're going to take a ball, and they're going to make and physically squeeze that hand until you're able, and as that hand learns to squeeze that day after day after day, you begin to regain activity in that arm, and you're able to move it over the next 6 months from then. And also speech, same thing. You can rewire the brain. Same thing with a substance use disorder. That's how you recover, is you rewire it a day at a time by doing the same thing over and over and over again. And that's why treatment is so effective, to help you get into that habitual component, because there is a habitual component that you've got to learn. You have a habitual component of drinking at 5 o'clock every afternoon.
Right.
You're right.
And you've got to unlearn that and learn a new habit of what you're going to do at 5 o'clock in the afternoon. You understand what I'm saying? So yeah. Mm-hmm. So that's part of it.
It's not as simple as just quitting something. You have to replace it.
You have to substitute.
Yeah.
It's a substitute therapy, and I'll tell people this all the time. Recovery is a substitute therapy for an active addiction. Yep, sure is.
Wow. So that's the other part too. Also, is it when people say, keep coming back, and we have these steps, we have a program, that you're saying that there's actually like voluminous research and scientific evidence to say that there's a lot of very important things that go behind the scenes. Most people don't know about all the intricacies of all this science. Maybe you don't have to have all that knowledge, but if you work a program,
if you read the literature, and that's what a lot of people don't know this day and time, but I've read every book AA's ever written, NA's ever written, studied it at depth. It will tell you, in the literature, even some of the older literature, the behaviors that you have to have in order to repeat, but they didn't know it was increasing your dopamine. Right. They didn't, but the thing about it is they know that it was getting you sober and keeping you sober. And storytelling. One of the greatest dopamine releases a person can have is tell a story. Mm-hmm. It's a normal thing. That's why people love storytelling. So what do they do in recovery? They have people get up and share their stories. And part of that has to do with overcoming a stigma. And the one thing I haven't talked about, which really prevents a lot of people from seeking help, is internalized shame.
Right.
The shame of not being able to control your own life because of a drug. Mm-hmm. And the thing about it is, that's why I'll guarantee you that's one of the greatest gifts of mutual help groups does. They help better than anything that I'm aware of, people overcoming that shame of not being able to control their lives as a result of taking a drug or a drink. And it's a relief, And that's the thing I tell people, this thing, it will be very difficult, but I have a wife who's in remission from late stage 4 non-Hodgkin's lymphoma. And it was very difficult, and she's in her 7th year now. But her first 2 years were awful because she was taking her chemo, and they used a targeted agent, and it eliminated most of the cellular cancers, but it still has the metastasis in her bone and bone marrow. And so we're sitting at this level of this metastasis activating and the cancer coming back any day. So we've learned to live one simple life. We stay out of crowds, and because she has no immune system, and we've had to limit our travel, and we've had to adjust our lifestyle, but we've been successful in that she's had a wonderful life for these last 7 years and continues to hope so. She's out now getting ready to decorate my daughter's house. She's feeling great, you know what I'm saying? Wonderful. But it takes a lot of work.
Right.
And I want to tell people is that the commitment, and that's why it is a spiritual commitment and needs a lot of human power behind you in order to get to this point to where you can recover. But anybody can recover. they can recover. It's simple, but it's not easy. You understand? It's not something, I used to do groups in Atlanta a lot, and I had a little magic wand. It had little stars, and they lit up, and people wanted to get well. So I just go over and I'll ding your ass well, you won't drink anymore and all that kind of stuff. But the thing about it is it didn't work.
No.
Because it takes work, y'all. It takes work to do anything to get better from a chronic disease. I don't care if it's diabetes or cancer or substance use disorder. It takes, and you have to maintain that treatment in order to continue to get progress from each day that you want to get out of there. So that's the thing.
There is no quick fix. It doesn't end overnight.
No quick fix. No quick fix.
Long-term solutions.
Long-term.
I want to go back and I want to ask about kratom and these gas station drugs. And
having reviewed and studied kratom for the last 7 years, and teneptine and phenibut, and now we got ketamine out there too, and several others at the gas stations. Kratom is in the world of pharmacy, we used to be able to use home remedies, castor oil, and we'd have what we call a wet and dry section in the pharmacy. And these old folks would come up there and they said, "Do you have some castor oil, or do you have aspidity? Do you have all?" And you'd have all these things so people could use, and they'd make their teas and links and kratom is a wet and dry in Southeast Asia. It is a weed tree. It's been used in the world that they come by with the medicine men and women in the villages, because they didn't have all the pharmaceutical drugs that we have. They have to use organics and things that's available to them, and still do, and will do probably for the next 100 years or so. But kratom was introduced to us as a pain reliever, and it is an opioid. It's a weak opioid. It has, depending on how it comes as a powder. You can buy the dried leaf, all kinds of oils and other things now. But the thing about it is, you use it long enough, it can create, one, a physical dependence, because it affects the mu receptor. And if you use high enough amounts, you can develop a tolerance. And if you stop abruptly, you can go into opioid withdrawal. Mm-hmm. A lot of people use it for pain, for various symptoms. Some people use it for intestinal IBS, Crohn's, because of the flash diarrhea and all, because it does help with that. But see, the thing that most people don't know, there's no regulation to the manufacturing of kratom. It comes packaged as capsules or powder or whatever, and each lot that you buy is different. There's no standardization. This contains so many milligrams of this per capsule, and if you take half a capsule or you take half a tablet, it'll do this and this and that. There's none of that information. It's just something that people have on the internet, and there's internet stuff. And so people now are using a lot of it now to stay out of withdrawal from legitimate opioids, instead of going to the clinics, MOUD clinics, where they use methadone or buprenorphine or something, or they may not have the money. They use kratom. And it works short term. But then over a period of time, they have to adjust upwards and upwards and upwards, and then you get into overdoses, you get into toxicities. We had a salmonella outbreak because of some kratom batches out west that led to some very serious illnesses in individuals. So kratom is a wet and dry. It is one of those things. It's been outlawed in several states. We're hoping that the state of Georgia will do the same and let it be reviewed and studied by the pharmaceutical industry so it can produce maybe something that would be good. Yeah. But these gas stations, they're all made primarily and produced so people can take them without being caught on drug screens. That's what they're for, and that's why we see so many different ones. So they don't have to be, if they're on probation or working for Georgia Power or somewhere and they have something and they need to take something like that, a normal drug screen won't find it. Of course, now the drug screening industry is now picking up on that, and they've got ways to determine that. Mm-hmm. So yeah. But the gas stations can be extremely dangerous because you don't know what actually the dose is per box that you buy or whatever you may obtain, if it be through a gas station or through an internet service.
If someone is addicted to kratom or one of the other gas station drugs and they go in for treatment, is the medication the same?
Yeah.
Okay. The treatment is the same?
Buprenorphine. We use buprenorphine usually for kratom because most people are getting have those severe withdrawals or have high dose, you know. And we also see that they're not using just kratom. They'll end up using hydrocodone. They'll use something else. You understand? There's no pure. I don't know a lot of just pure kratom users. And even the kratom industry has said, and they have information that says you don't need to be buying these products because we don't know what's in them. You know, that's one of the dangers that they've run into. And I think a lot of it has to do, you know, if you have a allergic reaction to aspirin and somebody was to die, then we've had this. They have a right to sue Bayer, if it happened to be a Bayer aspirin or whatever, St. Joseph, whoever made it. See, with kratom, there's no recourse. There's no one who you're going to sue. You know, there's no protection of the consumer, and that's my concern. See, a pharmacist is trained as a medication safety expert. We are the gatekeepers, both on the pharmaceutical side, prescription side, and also the over-the-counter side. And so that's why you see only certain things in prescription in pharmacies that you would maybe see in a health food store, because they're not regulated the same. And we want to make sure, and being trained, that this dose would work for you and this would be safe for you. And if you had this drug, maybe you need to take this dose or you don't need to take it at all. You understand what I'm saying? That's what it's about. But now, because of the internet and the gas station, there's no regulation. And that's the danger, the medication danger. So we'll see more deaths and more complications as a result unless we remove them from the market. And that's what, you know, I know in Georgia they're trying to do that now. So, kratom, anyway.
I also know another trendy thing, like you talk about gas station drugs. Another one is more behavioral. I was just reading something about the epidemic of online sports gambling and those. Is there a difference between being addicted to a behavior versus being addicted to a substance? Is the science
not to the brain.
Not to the brain.
Same process. Same chemicals. Y'all have to understand the brain operates. It's simply chemical reactions changed into electrical currents back into chemical reactions. So it doesn't matter if it's an eating disorder or if it's a gambling disorder or if it's a shopping disorder or, you know, like shoes. I love shoes. I have too many shoes. I won't tell anybody but I have to really watch my shoe buying because you end up, you know, I had to clean out my closet recently and I had 140 pairs of shoes.
Oh, goodness.
You know, and I don't, you know, it's just, but anyway, but it is the same chemical. It's the same process.
So that whole whack-a-mole theory where you beat down one addiction and up pops another one.
Compulsivity.
To back that.
Compulsivity is the primary symptomology of an addictive disorder. A substance use disorder or addictive disorder includes the other disorders. And so that has to do with simply a lack of dopamine. See, compulsivity is regulated in the prefrontal cortex primarily. If you've got enough dopamine up here, it does two things. You're not compulsive, and the other thing it is you've got hope and excitement to live. You start diminishing your dopamine, two things happen. You become very compulsive, and also you lose hope, and you become suicidal. So the thing about it is dopamine, and that's the problem. When you have one disorder and it creates that diminishment, as I talked about earlier, yes, as soon as you stop that, then the brain's going to say, I got to have this drug in order to increase my dopamine.
Yeah.
And so you substitute. So how many times have I been in treatment and I've seen individuals first or second week, they fall in love with somebody in group. Oh my God. They hook up.
Yeah.
And they increase their cigarette smoking. They increase, you know, they're over the counter taking medication. They increase eating their high fat, high carbohydrate foods. Yes, there's multiple isms associated. So you substitute, you stop one, another one can pop up, and it does pop up. That's why you got to have a recovery program that manages those as they come. Very important, very important. So
the people used to talk, when I was growing up, talk about, oh, so-and-so has an addictive personality.
You can have a compulsive personality without having a substance use disorder. They're OCD,
Yeah.
ADHD. Those are all addictive personalities, but they don't lead to a substance use disorder. You can have compulsivity, and you can have compulsivity in a positive way, and OCD in a lot of cases is a very positive thing. People keep things very organized, and the same thing with the opposite part of that you can have OCD and have extremely disorganization. Hoarding is an OCD disorder. Has to do with disorganization. You understand what I'm saying? So you can have these dysfunctions, but yeah, you can have an addicted personality, but doesn't mean that you'll end up with a substance use disorder.
How about, last kind of sciencey question, the connection between substance use disorders and mental health?
I was going to ask those questions too.
Same biochemistry, y'all. See, the disparities of mental health illnesses is either too much or too little neurochemistry in certain parts of the brain. And what substance use disorders do, now see, a lot of people with mental health issues or mental illnesses will use psychoactive substances. Alcohol is great for depression in the beginning. Nicotine is great for schizophrenia in the beginning. You can use cocaine, is great for ADHD. Marijuana is good for ADHD, depression, anxiety, pain. Has to do with deficiencies of certain, and they're all tied together. So 40% of individuals with substance use disorder also have a co-occurring mental disorder. And see, you have to understand when people use psychoactive substance, it makes them either feel good or feel better. Those are the two reasons they use it. Feel good, feel better. Most people with any kind of co-occurring disorder, when they use a psychoactive substance, is in order to feel better or more functional. Mm-hmm. And that's where they get into trouble. And so when they get into trouble, they build a tolerance very rapidly. And the danger there and the reality of that is if they stop using that psychoactive substance, that mental illness is usually worsened. You see, mental illness worsens as you age anyway, because you have a diminishment of chemistry as you age. And when you have an alteration in that chemistry, those mental illnesses will diminish. So that's why you bipolar disorder, and you have high risk of suicide for that anyway, but as it ages, they have higher risk of suicide because that brain chemistry is diminishing. And you can't keep it managed very well with just medications because of adverse. But yeah, that's how it's tied. They're all tied together. They're all in one family. It's all the same dopamine, it's all the same serotonin, it's the same GABA, glutamate. All those are tied together. See, a lot of substance use disorders will have symptomology of mental illness. Alcoholism for years was looked at as a bipolar disorder.
Yeah.
Manic depressive disorder they called it back then, because you had ups and downs, ups and downs.
Yeah.
And it will do that. It will improve it short term, and then it will create a worsening of it. So yeah, they're tied together.
So up until now, you've been describing addiction in a way that feels personal, but also deeply informed. Would you be willing to share how much of what we've been talking about is also your own lived experience?
Well, I've been sober as of March 17th, 43 years.
Wow. Congratulations.
Thank you. My daddy was alcoholic. He late, as I said earlier. My grandfather was murdered in a alcoholic blackout. Left my grandmother in the middle of the Depression with 4 small children. So I always had that knowledge, coming up. My process was I had polio when I was 2 years old, completely paralyzed except for my eyelids. Spent a majority of my childhood at Warm Springs, Georgia, rehabbing. I was in a group of 7 children that were all affected by polio. We'd gone out, I think my mother said we were at a Sunday school swimming party and went to a swimming hole. And out of those 7 children affected, 3 died immediately. The other 3 that survived they spent the rest of their lives in wheelchairs. I was the only one that was able to rehab and walk and talk.
Wow.
But the thing about it is, it scarred me deeply because I was a national poster child at 4, had to wear the braces and all that, and of course you go to school and the kids, I can't run and can't walk, can't do anything the kids do, and they would call, crippled and all that stuff. So I had a lot of scars. And then I took my first drink under threat of my oldest brother and cousin, so I wouldn't tell my mother they were drinking. That's kind of how it started. But when I had that first drink, a beer actually, a black Carling beer, awful tasting, but it made me feel different, not knowing that it did. And so what that did, I didn't immediately start drinking then, but I had the memory of what that did. And so anyway, over my adolescence, I was very successful because I had a very good brain. And so I became a president of student body. I was in all the honor clubs and was sent to all these. We were from a very limited high school, so I was put in competition with the main high school in Albany and won all these awards outside of Albany High School. I was one of the first students to do all that. So I got all this recognition. So I got full scholarships for my college. I went to pharmacy school on full scholarship. But anyway, meanwhile, while I was there, I would have two personalities. I'd have a studious personality and then I'd have a drinking personality. And I also got into gambling. And so I became a notorious gambler and very successful at one. But I was controlling my drinking. In other words, when I played cards, I didn't drink. Mm-hmm. But I ended up in a dangerous situation. I won't go into that in detail, but the thing about it is it made me decide not to be gambling anymore on that level. So when I stopped gambling, guess what happened? I started drinking. And of course, I'm a pharmacist, so go into pharmacy and you couldn't drink like I wanted to. So, and I was working, these stores that I was the only pharmacist and had to work 12-hour shifts for 3 weeks in a row. And so, of course, the average thing was amphetamine. So I found amphetamines and other drugs. Make a long story short, I bottomed out and was busted in 1983, March 17th, and St. Patrick's Day, and went to treatment for 3 years. My first year, I could not remember anything. Couldn't drive a car. So I was with Doug Talbot, Dr. Talbot, who's the father of addiction medicine, one of the fathers, and he took me under his wing, and so he kept me for another 2 years until I was able to regain my functionality. And so I worked with him till 87, and I went back to make amends to my community in North Georgia. And anyway, long story short, went back to pharmacy, got my license back, and I was developed into a counselor. Decided I wanted to know, and the reason I know so much about, I didn't believe people when they told me I had a disease. I didn't believe that. I just thought I was bad. I thought I was immoral. Mm-hmm. And so Doug sent me all of these research, and I got very fascinated and watching these researchers and doing the research, and the rhesus monkeys at Emory and then at Southern Cal and in Minnesota and Hazleton and other places, and then I caught on, so I decided I'd do that. So worked with them and started private practice with a psychiatrist, and Dr. Talbot went back. And so the long story short is that I regained my memory. I have a photogenic memory, and so that helps me. And I went back to school, came to the University of Georgia for the second time. I got my doctorate, wanted to research. Actually came here to the Commencement Center. This was my clinical site. And I brought med students as well as pharmacy students over here, and we'd sit at this table and we'd teach them about addiction. We'd put them in with the students, their 5-6 week rotations. They would learn what treatment was about from that standpoint. And then we'd process them and, send them on their way, and they still want to know, So that's what I did. I created curriculum here at the University of Georgia until my wife got so ill that I had to retire in order to take care of her. But yeah, I'm very content and very happy, very excited about recovery. That's why my main thing is what I was taught is that I was always, the one thing spiritual is that every day I need to carry the message, whatever that message may be, to somebody who's a newcomer. And that's why I'm here this morning, spending my morning with you guys, and to make sure that I do carry the message, but I do it on an everyday basis. So I got webinars coming up next week, so it's exciting. But my main reason is to try to reach out to people who don't think that they can get better, which I was one of those people. But it took a long time, but I'm still here. I do the same things that I did the first day. I read my meditations, I get up, I talk to my sponsors, I do the things I'm supposed to do because I am a type 2. Mm-hmm. My brain doesn't accumulate dopamine. Mm-hmm. And that means some days it's harder than others. But that's why I always surround myself with recovery and its dimensions and spirituality and always reading. I'm always studying about how that we can get better and what can make us better. And so that's why I'm here. But yeah, that's why I decided I would do this. And God has blessed me in many ways, many ways. I'm very secure. He got me through this very horrendous brain surgery and continues to bless me, bless my wives and my children. And so, yeah, it's a great life. It's a great life at the moment.
That's wonderful.
So thanks for asking.
We really appreciate you coming and sharing your wealth of knowledge and your personal experiences. We may tap back into your knowledge sometime down the road as another part of this series.
That'd be great.
How that manifests.
We'd love to do that.
All right. Thank you so much.
Thank you.
As we wrap up this episode, what stands out most is this: addiction is not a failure of character. It's a change in the brain.
What we heard today helps explain why people can want to stop and still struggle, why willpower alone isn't enough, and why real recovery takes time, support, and consistency.
Recovery is not about flipping a switch. It's about slowly rebuilding and rewiring one day at a time. And maybe most importantly, it reminds us that healing is possible.
If someone you love is struggling, know that help is out there, and you don't have to do this alone. Thank you for joining us for the Essence of Recovery.
Until next time, may you trust your own path, honor your healing, and remain open to the growth that unfolds along the way. This podcast is sponsored by the Athens Area Commencement Center in Athens, Georgia. Thank you for listening.